When my baby was 6 weeks old, we were visiting a friend who happened to also be a pediatric ophthalmologist and colleague. We were sitting on her back deck, enjoying a late summer afternoon. My husband was holding my daughter, and I was sitting next to him, when suddenly my friend pointed to my daughter and said, "Look, her eyes are crossing." So initially, I wasn't too concerned because I knew my daughter had pseudoesotropia. She really had all the classic features. She had a broad, flat nasal bridge. She had almond-shaped eyes with epicampal folds. And she had a slightly smaller eyelid opening. So you didn't see as much white in that left eye, and it often looked like it was turning in. But when I looked over at her, her eyes were really crossing. And my mom brain kicked in, and I blurted out, "What should I do? Could there be something wrong with my baby?" So the underlying basis for my panic was my ophthalmologist's brain envisioning my daughter developing infantile esotropia. Infantile esotropia is a large angle, constant esodiation that presents within the first 6 months of life. You've probably also heard the term congenital esotropia used, but the truth is that this condition rarely is present at birth. Like all ocular misalignment, congenital esotropia affects binocular vision, or the ability of the brain to use the eyes together. But because it occurs early during the critical period of binocular development, early detection and treatment can significantly improve visual acuity outcomes. And early may be earlier than you think. So what do babies' eyes look like during the first months of life? In a study of over 3,000 infants, eye alignment in babies in the newborn nursery were assessed. These babies were then followed up after discharge by having an ophthalmology fellow sitting in the pediatrician's office during Well Baby Clinic to look at these babies. And they find it's very common for the eyes to be turning out. Up to 70% of babies will have some sort of exodeviation. But it's not common for babies' eyes to be turning in, with only less than 1% having eye crossing at birth. But all these babies got better, and none of them developed infantile esotropia. Of the ones that did develop infantile esotropia, all were either straight at birth or turning out. The children that went on to develop pathological strabismus tended to deviate from normal infants at about 2 to 4 months of age, right around the time that we start expecting these babies to develop fixed and follow behavior. So some babies with esodiviation will get better and others will not. Are there certain characteristics that can help us identify those that were not likely to get better? The congenital esotropia observational study enrolled babies between 4 to 19 weeks of age who had an esotropia. And they found that most of these babies did not have signs of infantile esotropia, and up to 30% would spontaneously resolve. The ones that were likely to get better were younger infants with a smaller ankle deviation that was often intermittent and variable. If you had a large angle eye crossing that was constant and you were older than 10 weeks of age, this was unlikely to get better on its own. So for large, I put 40% diopters, and I just wanted to go back and talk about that, because oftentimes you probably see in our notes, we write different numbers with prism diopters, and I've been talking about small deviations and large deviations. So what does that look like clinically? The Hirschberg test is a simple way that you just use a light, pen light, and shine a light on the baby's eyes. If the baby's eyes are straight, the light reflex should be centered in each eye. So oftentimes when parents come in concerning of an esodiviation, we often go back and look at their iPhone photos and try to look at the light reflexes to see if they're centered. Now, if the eye is turning in, the light reflex is going to be deviated temporally. And how far that light reflex is deviated gives us an estimate of how big the strabismus is. There are certain landmarks in the eye that help us with this. So if the light reflex lands at the edge of the pupil, that is about 30 prism diopter esotropia. If it lands at the mid-iris, that's about 60 prism diopter esotropia. And if it lands all the way to the edge of the cornea, that's about a 90 prism diopter esotropia. So we consider small deviations probably 15, less than 20. The 30 prism diopter would be sort of a medium deviation. Anything about 40 we consider large. And the very bottom one, that's like extra large. So going back, now we know there is a clinical profile of babies who will likely not get better with their esotropia. So they're older infants, older than 10 weeks, with a constant deviation and of a large ankle. Why do we care about this? Why do we want to identify these babies early? Because time is of the essence, and it can make a difference between a child who uses both eyes together and one who does not. The treatment of congenital esotropia is surgical, and good surgical outcomes are not only about achieving straight eyes and good alignment, but it's also about developing binocular vision or depth perception. So we know that the onset of depth perception occurs between 3 to 5 months of age, right around the time where we start seeing infantile esotropia. Stereopsis increases rapidly within the first 8 to 18 months of life, and then sort of has gradual improvements till about 3 years of life. We know that babies who have surgery early for infantile esotropia have a higher chance of developing the ability to use their eyes together. So how early is early? So as with anything, time earlier has become earlier over the years. There was a time when early was school age and 4 to 5 years seemed early. But in the 1980s, Malcolm Ng performs a somewhat landmark study where he went around and personally traveled to 3 different countries, examining babies treated by 7 ophthalmologists. I love the 80s. I feel like they had time to put the fellow in the pediatrician's office. They had time to travel to all these countries to look at these babies. But he found that babies whose eyes were aligned after 24 months had a low likelihood of developing binocular vision. So it was felt that these babies should have their eyes aligned before 2. But we know now that earlier is even better. When we think about early surgery, we not only think about younger age, but we also think about shorter duration of misalignment. So in a study by Birch in 2000, she looked at 3D vision results for babies who were aligned, some younger than 6 months of age and others up to 24 months. And she found that if your eye misalignment has been around longer than 12 months of age, your chances of using your eyes together almost go down to 0. 4% develop some sort of 3D vision. Whereas if your eyes were realigned within the first 3 months of misalignment, that number went up to 65. She also found that babies had better quality depth perception if you operated early. And there are many factors that we use to help decide what the best timing is for each individual child. But we can't minimize the duration of misalignment unless we see these babies early. So we do want to see them. If they have a large or constant eye crossing, their eyes are turning on all the time, there really is no reason to delay referral. We want to see them right away. So now I'm going to go back to my original question of what should I do, and I hope I've answered some of those questions. So we know that babies within the first 3 months of life will often have a variable strabismus. These deviations tend to be small, intermittent, or variable, and likely represent immaturity of the ocular motor system. They can be, but by 3 months of age, we expect them to have fix and follow behavior. So this type of strabismus should resolve. If not, we want to see them. Taking into consideration that you are performing your right reflex test, that you are making sure the eyes move around like they should to rule out any sort of other etiologies. But these babies are different than the ones who are turning in all the time. We want to see them right away so we can start assessing them. So you may be wondering what happened to my daughter, Callie. So luckily she was young, she was 6 weeks. Her deviation was intermittent, and it was not large, not small, it was medium. So her ESO deviation resolved, and she did not develop infantile esotropia. Thank you.